Equally, the litigation authority, external claims, had come in and assessed the organisation at level 2, out of level 3 as a maximum. So again, they were doing pretty well. A lot of trusts were still at level 1 at that point. Level 1 meant you had policies and procedures in place. Level 2 was meant to indicate you had policies and procedures and they were effective, and there was clear evidence of effectiveness and demonstration of them having an impact with patients. And then finally, in the same year, the Trust declared they were non-compliant with 3 out of the 23 core standards around the Healthcare Commission's criteria. So some self-awareness and some recognition that certain things weren't in place. One of the important parts of the 3, particularly related to nursing and the audience this morning, was around that nurse training of equipment and the ability to have recorded that all nurses had been trained in equipment on their wards or in their areas, and it was up to date and they've been trained in the last year. So the organisation dismissed that as a lack of record keeping rather than the nurses actually hadn't had the training. But of course, as a board, as an organisation, you couldn't challenge that and argue it because the processes, the systems weren't there to capture whether a person had been trained or not. So it's that verbal assurance and that kind of reliance on a lot of verbal assurance in the organisation because systems and processes weren't there. So I think that's an important slide for me in the sense that if I'm a board member in mid-staffs, I've sorted the money out, we're now delivering surpluses, and by crikey, look where we've got to as well in terms of quality of care. So as a board, they weren't looking internally and looking for further assurance. They put a lot of credence to external assurance. And part of, I guess, my personal reflection and my personal learning is these regulatory bodies come in for a number of days into an organisation, they do a quick kind of litmus test, kind of dip test in the organisation, and they provide a viewpoint on the back of 2 or 3 days kind of inspection or visit to the organisation. And boards are placing, and still are placing to a large degree, more reliance or more credence on that evidence than actually the day-to-day noise emanating through the organisation and through the trust. And there's certainly a lesson there around balance of internal and external assurance. The main findings of the various reports that Liam referred to, Robert Francis, the Healthcare Commission, Professor Alberti, Dr. David Colintome, we were visited by a number of people and organisations over the 2 years I was there. The main findings, particularly related to the governance elements, is there was a long history of poor quality information, and because of that, every time something really kind of fairly negative came out, the board dismissed it as, well, that's about poor record keeping. And even when the mortality statistics came out, that was put down to poor coding, poor clinical coding, and never really looked beyond the coding issue because they were blind to that other noise going on, because they're getting the external assurance saying, no, we're an improving organisation, we're really good, we've got level 3, level 2, we're good quality care, Healthcare Commission. They were not believing in this other triangulated bit of evidence, a bit of noise that was going on. We talked about the disconnect between the board and the ward already, and therefore the board weren't seeing an appropriate array of assurance in terms of what was actually happening in the organisation, particularly at ward level. The information that was going to the board was often aggregated to the point of almost being meaningless. I think complaints is a really good example here, where if you read individual complaint letters, some of them were absolutely horrendous and really moved me when I was, in the absence of the chief exec, having to sign individual complaint letters. They were absolutely awful, and I started to see some of the detail. Those complaint letters didn't suddenly start in 2008. The chief exec and others must have been seeing the individual complaint letters way before that, but by the time things were reported to the board, things were just bucketed into quality of care, communications, facilities, and things like that. So what does that mean? Quality of care could cover a whole myriad of things. So the board weren't seeing a level of detail that enabled them to challenge or to gain a real understanding of some of the more granular level of issues that were going on. And there really was some quite. quite horrendous complaint stories coming through, I can assure you. Equally, a lot of the complaints were around basic ward-based nursing care, around hydration, nutrition, medication, training issues that we talked about, soiled beds, dirty commodes, etc. Real basic stuff. The board, or anybody in the organisation for that matter, were completely unsighted because there was no mechanism or system to capture that activity going on in organisation. And even now, there's still relatively few trusts who routinely report ward-based or nursing care indicators at board level. So even though the reports came out and everyone was told, go away and make sure your trust is not a mid-staffs and could not be a mid-staffs in the future, I would still challenge probably around 80% of trust boards to say, you still don't know whether you could be a mid-staffs because they're not seeing some of the right data in reality. There was a culture of non-reporting. Two reasons. One, we talked about the bullying and the harassment earlier on in Liam's bit, but also because there's breakdown in communication between the ward and up to the board, and then from the board, as importantly actually, the board down to the ward, there was a perception that even if we raise issues, nothing ever happens about them. Now actually there were instances, and there are minuted instances, where the board did respond to things and did act actually, but actually that communication back down to the wards didn't happen, or to that originator of the incident or of the complaint. So to all intents and purposes, from their opinion, nothing's happened, because they couldn't necessarily see something or weren't aware what was going on. So people stopped reporting, because what was the point? Nothing ever happens. We had out-of-date policies and protocols. So again, how could you start to hold people to account for their practice? Actually, because there wasn't an up-to-date framework of policies and procedures against which you were saying to people, this is how you should be doing X, Y, and Z. We had action plans coming out of our ears. Every single complaint had an action plan. Every serious untoward incident had an action plan. Every external review, they'd always find issues and concerns, had an action plan. We were great at action planning, fantastic. But actually, nobody really monitored the implementation of those action plans at all. The creation of the action plan was seen to be the end point in itself. We've now got an action plan, so somehow it will just happen. But actually, nobody was monitoring and ensuring those actions were implemented, and as importantly, they had the desired effect in terms of changing practice or changing outcomes, and that was the expectation. So nobody was really closing the loop in that sense of, we've got an action plan, have we put it in, is it having the effect? So again, things like clinical audit, etc., were not being used in the appropriate way. Risk registers, well, we could forget about that. There were no risk registers of any great degree when I arrived. It was seen as a bureaucratic process. Nobody really understood what a risk register was, what its purpose in life was, and how it really fitted into the overall processes. As I just touched on earlier, clinical audit was very disconnected from the overall governance process and was not used as a kind of clinical governance tool. It was very much seen as the medical staff doing their own things in their own areas of interest, or junior doctors doing their clinical audits because they need to as part of their training, or we were doing a number of national audits because we had to do them, and we fed this kind of central beast over the Department of Health. But there were no audits whatsoever that related to anything that was going on locally, or any of the noise or concerns being raised through any of the systems in the trust. So in terms of the actual learning itself, starting with board assurance, boards certainly need to ensure they are cited both on internal and local issues, as well as the external mandatory stuff. And even now, when you go to a number of NHS trusts in England, you ask them about quality and how they're assuring themselves around quality, they'll talk about the national targets. So they'll talk about 18 weeks, they'll talk about A&E, the cancer targets of 31 or 62 days. They might get into kind of VTE, pressure sores, but they're all things that they've been told nationally are important. There's very few trusts are gathering data and themes and trends from their internal systems around incidents and complaints, etc., to understand what's wrong, what's not working in my organisation, what do we need to be monitoring and improving on locally. So there's no real balance between that kind of local, internal look at the systems and what we're told to look at externally. So everyone says, yes, we're doing quality profiles really improved in our organisation, but actually it's what they're told to do. It's what they're given. There's kind of learned helplessness almost around quality. And I think that if we do the national stuff, then we'll be a quality organisation. There's something about alignment with the organisational priorities, and again, it's completely missing in part of the disconnect between the board and the rest of the organisation in mid-staffs was the board were busily setting corporate objectives at the start of every year or priorities, etc., for themselves, but actually had no way of monitoring or assuring themselves in the year that actually they were happening and they were having the desired impact or effect. And even now, every organisation, every NHS organisation has to have a set of quality accounts as well as their annual financial accounts now. And within there, they have to state their top 3, 4, 5 quality priorities for the next financial year. And too often, they're not monitoring them. I mean, I had one, couple of dealings with some in the last few weeks, a couple of examples. One talked about noise at night was an issue for them. They picked up through complaints, noise at night. So that was one of their priorities, to sort out noise at night. Nothing wrong with that. How are you doing that? How do you know? How are you doing that? So what's your action plan? And equally, how do you know it's having the desired impact? And there was no mechanism for monitoring it. So they've stated that's one of their 3 top priorities for the next 12 months, but actually they didn't have a clue whether or not they're actually delivering on it at all. So it became a sound bite in reality. That's all it was. Or we have other organisations who are far more generic and say, we want to improve patient experience. Yep, we all do. Nothing wrong with that, but that's a vast subject in its own right. So where do you start? What are you doing? As opposed to just, this kind of overarching theme or view, really.